Hey folks, this is Ian Steele, Editor-in-Chief of CGEM, and today I'm going to walk you through how you can quickly access our brand new easy reading format. It starts when you receive that exciting email from CGEM telling you that the latest issue is available. If you click, you will come to your home page. You have to log into the CAEP website, and you'll see, if you can read that bottom left, they show you the January issue. You click on that and it will quickly take you to this home page of the Easy Read version. You'll get this little alert that we've got a couple of nice new navigation options that I'll show to you. So you can go then here to the table of contents, and you want to read this article on saving emergency medicine. Sounds interesting. So you click on it and it will take you directly to that article on page 15. And you will see here, Saving Emergency Medicine by some esteemed authors, Paul Atkinson, Ken McGregor, and Grant Innes. Once you finish reading it, go back to the first page and go to the top where you see that return button. You click on it and it will take you back to the table of contents where you started. And then you can choose another article. The only little tricker here is if you are reading an article, to get back to the table of contents, you have to go back to the first page of the article. So that's it, and I hope you enjoy.
Thanks very much to Dr. Steele for how to read all those great articles in CGEM. My name is Louise Rang, and I'm an emergency physician in Kingston, Ontario, and I'd like to welcome everybody tuning in this evening, this afternoon, and indeed even Thursday morning. We've got lots of time zones covered in this one. I'm coming to you from the traditional territories of the Haudenosaunee and Anishinaabe people, and I'm grateful to be able to play and work on these beautiful lands, especially during these fantastic, cold, snowy winter days. This month's CAEP National Grand Rounds is part of our CAEP Emergency Medicine Wellness Week, and our theme this year is Humans, Not Heroes, which reflects the challenging times in which we find ourselves. A huge thank you to Dr. Lisa Fisher, who's the coordinator for CAEP Wellness Week, and who has boundless energy and imagination and seems to settle on exactly the right theme year after year. She oversees the content for the whole week, and in true EmergeDoc fashion, she's working tonight. Thank you also to the rest of the organizing committee, Drs. Rod Lim, Judy Morris, Chow Pham, Suzanne Boramond, and Megan Kerr, and to all of those who've also contributed content. Thank you. If you haven't had a chance to look at the videos from Monday and Tuesday, make some time to go to caep.ca to check them out, but not right now because we have a great talk coming your way. New content will be posted tomorrow and Friday. And of course, thank you also to CAEP Head Office, so Isabel Garcia, Shanna Scarrow, and Gail Chapman, who have helped our visions come to life. Questions for tonight's session can be entered into the chat and are being monitored by a medical student, Miriam Zadeh, who will organize our conversation and our chats, and we will try our best to get you an answer. CAEP's Scientific Committee has reviewed the speaker's conflict of interests, and they're shown on this slide. Okay, on to tonight's main stage. It's my great delight to introduce our keynote speaker, Dr. Eve Purdy, who really needs no introduction. Many of you will know her from her publications or lectures, opinion pieces, or blog posts. Eve is currently a consultant at the Gold Coast University in Australia, and having completed her residency in emergency medicine at Queen's and an MSc in applied anthropology from the University of North Texas. Tonight, Eve will talk to us about the impact of EM values and culture on team performance. And appropriately self-referentially, she will work with a team of Australian colleagues to illustrate her points. Eve will introduce the team shortly. I happen to be lucky enough to know Eve from her time at Queen's and can say that she's left us all just a little bit richer for having been here. One of Eve's regular pieces of wisdom that would come up in rounds or simulation was for us to name the dynamic, to put words to those feelings that we are noticing in that very moment. And for many of us right now, during these COVID times, the dynamic is one of exhausted, worn out, edgy, uncertain, fatigued, done with COVID. It's been a truly hard couple of years. But it turns out that this talk might be part of the antidote to at least some of these feelings. Eve has a unique ability to cultivate a sense of wonder and awe about our specialty, and indeed our profession as a whole, that's simply just restorative. Eve's unfailing hope is that we can always be better, perhaps just 1% so, and that we owe it to ourselves and our colleagues just as much as our patients to realize this. Eve's work integrates wellness, QI, simulation, and team dynamics into a near-perfect marriage, and it's infectiously rejuvenating. So, Eve, I'll name the dynamic excited and appreciative. Thank you.
I'm thrilled to be here today, and I'm presenting to you from Australia. I'm on the land of the Yugambeh people, and I'd like to pay respects to the traditional owners of the land and their leaders, past, present, and emerging. I'm so thrilled to be speaking and sharing today some thoughts about who we are as emergency physicians and who we are as a community of emergency practitioners. And together, I'm hoping we can think about a little bit about what we might become. I'm going to start by asking you to take about 30 seconds. You can do this on your own, or if you happen to be in the same room as some other people. I'd like you just to think about what is emergency medicine. If you're so inclined, you can feel free to share some of those thoughts about what our specialty is, what makes emergency medicine in the Zoom chat. Now, I've spent a fair bit of time thinking about this exact topic. What is emergency medicine? What are our values? Who are we? What's important to us? And as it turns out, there's not actually an easy answer to this specific question. Even if you go onto the CAEP website, there's not actually a definition of what emergency medicine is. As an anthropologist over the past 3 years, I've spent time exploring emergency medicine across a number of contexts to try to get to the heart of what emergency medicine is. This is the best and the closest definition that I could come up with, one that aligns with our values and the way that we see our work. Capably navigating acuity and uncertainty together. It's a pretty simple definition, but we're going to break it down. We might go to the easiest word in this whole sentence, acuity. As emergency physicians, we really value looking after the sickest, the most critically unwell patients. We're pretty good at it. We also like and think we're well positioned to look after patients that may not be as sick, but who need some immediate medical needs and need to be connected with services quickly. We're also pretty good at that. Uncertainty is a really important and central part of our work. Often, we don't have the right answers. We're making decisions with limited information, and we're doing our best. We know that we may not be perfect, and we're actually pretty okay with that. When we think about what it means to navigate all of this, well, that's where things start to get a little bit different. We navigate care paths for individual patients. Somebody comes in with belly pain and we decide that they need a CT scan. We all know that sometimes that can get a little bit more complicated than it seems. We navigate the system for our patients. The system is becoming more and more complex. And emergency physicians are at the heart, at the center of connecting the dots for our patients who need us to. We do all of this while balancing the resources that are available at the system level. We see navigation as an important part of our job. We do all of this, acuity and uncertainty and navigation, we do this together. We do this with other people in our emergency department, the nurses that we work with, the respiratory therapists, the porters. This is our emergency medicine team. It feels like a family. We do this with other people in our hospital. We build relationships with our colleagues in other departments and in other places. They're a critical part of doing this together. And perhaps most importantly, we do this with our patients, and we do it with their families. We navigate uncertainty and acuity together. So where does this qualifier come from? Capably. Why does capably find itself to the beginning of this sentence? Well, capably is there because it turns out that emergency medicine is a part of our self-identity. Being able to navigate acuity and uncertainty together is a part of who we are. I'm not just an emergency physician. I don't just do emergency medicine. I am an emergency physician. And when I do those things well, I feel fulfilled and I feel happy. So when I walk into my emergency department every day, I'm expecting and I'm hoping and I'm inspired because I think that I'll be able to capably navigate acuity and uncertainty together. And when I can do that, it is a great shift. The reality, though, is that it's starting to not feel like that all the time. Sometimes we head into work and it feels like we're barely managing increasingly complex and we're shouldering relentless uncertainty and we're not doing it together. Heck, sometimes we're even doing it intense. This is not the same as the idea of what we have, of who we are. Now, I'm not going to belabor what contributes to each of those things that have changed, got us far away from our values, because I think the people who are on this talk and who are on this call know what those are in your own context. There's any number of contributing factors that are getting us further and further away from our values. And that's the real problem. I want to introduce to you this term called value incongruence. Basically, that means that the way that we are doing our job is very different than the way that we hope to do our job. And this is more important than it just being a subtle difference. It gets to the heart of what makes us think that we are practicing emergency medicine. This is what happens when we start to experience a degree of value incongruence. We become a version of ourselves that we don't recognize. And I suppose this drift away from who we are, this capable emergency physician, is why we've started to have lots of discussions about wellness. And many of those discussions have centered at the individual level. And I think CAEP has done an excellent job of starting to move that dialogue more towards thinking about how the systems impact individual wellness. Because there's no doubt, while we're drifting away from ourselves, our systems are as well. Our emergency department starts to look less like this and more like a version of itself that we don't recognize. And so while at the systems level, we're doing all sorts of important work to get back to managing and working in a way that aligns really closely with our values, it's critical to realize that there's something else that we can impact on a shift by shift basis that may allow us to manage this dynamic, to manage this drift in real time. Because we can't solve all of these problems immediately. The need to solve them has never been more urgent. I think we saw this in a recent survey that came out in the Canadian context, showing that 60% of emergency physicians are showing signs of burnout. And the systems level fixes that we need to get back to our values are absolutely imperative. And I don't at all want this discussion or our panel today to get away from the importance of that at a systems and organizational level. But I'm hoping that as individual practitioners, what we can start to think about is there are small things that we can modify. And those things are our teams. What I've seen as an anthropologist over the past 3 years is that our teams are the buffer between our system level failures and our individual patients, but as well as us as individuals. Our teams are what allows us to mitigate this drift in real time. So we've all worked with teams that are dealing with a complex, challenging problem, and it's going really well. There's a degree of clarity in the air. There's this communication that's happening. Everything's going right. But we've also worked shifts where we start to drift a little bit away from that. It might even be on an hour by hour basis that our teams have clarity. Perhaps they look nothing like we want them to, and somehow we find a way to drift back. We find a way as teams to capably navigate acuity and uncertainty together. Our teams are at the center of this on a shift by shift basis. Our teams have the ability to manage navigate acuity and uncertainty together. And so I'm hoping that what we can think about today is our teams as this buffer. They're really this protective mechanism that we have right now in the barrage that is emergency medicine, that while we sort out all the mess, we can focus on, and we can actually mitigate and impact each and every shift that we're on. And I actually don't have a desire to tell you how to do that. What I wanted to do was invite some of my colleagues who I work with every day to join me in having that discussion, to join me in discussing some of the challenges that we have while doing so. But more importantly, to think about the things that they do when they show up to work in a challenging environment to help their teams be the best possible buffers that they can. So without any further delay, I am going to go ahead and introduce an excellent and an inspiring group of Australian clinicians in the emergency department that I work with. And we are going to get a discussion started. I would certainly ask you to have any questions that you've got for the panel. Feel free to put them in the chat and we'll try to address them as we go. But I would first like to welcome Michael Summers, who we will affectionately refer to as Summers from now on. He has been an emergency department nurse for the past 8 years in a variety of roles, including as a clinical facilitator and as a part of the business practice improvement team. Summers has this unique ability to use humor to bring people in teams together. No matter the circumstances. It's like nothing I've ever seen before. And I am thrilled to have him join us. How are you today, Summers?
G'day, Eve. I'm absolutely stoked to be here. I'm very excited. I am well today, a little bit nervous, but mostly excited, to be honest.
Wonderful. And you'll see that Summers is wearing our excellent teal colored scrubs that the nurses in our department wear. And repping them proudly. That's wonderful. Well, we look forward to your insights. Next up, I would like to introduce Samantha Luck. Now, Samantha deserves a giant round of applause because she is in the final days of her specialist training. She has 2 more shifts left before she moves to regional Australia, where she will be a consultant emergency physician in Toowoomba. And she'll continue training in specialist pediatric emergency medicine alongside that. I've asked Samantha to join our panel today because over the past year working with her, I was a new consultant and she was a registrar in our department, and seeing her ability to lead her colleagues and her peers and her superiors from the middle is something that I have really, really admired. And I think we can learn a lot from your ability to drag your teams along with you. So thank you for joining us, Sam. How are you today?
Hey, Eve, great, thanks. That's very kind of you to say. I didn't realize I was doing that, so it's good to know.
I should have done a better job of telling you. We might get into little bits about appreciation and why that matters and how we can do a bit better, but obviously we should have a discussion offline. Next up, I'd love to invite Warwick Isaacson to join us. Warwick has an interesting history. He is a marine biologist turned high school teacher, turned emergency physician. He makes the best fish tacos on the Gold Coast the same day that he catches that fish. So if you ever make it to the Gold Coast, get work to fish and cook for you. Beyond that, in our emergency department, he brings a lens as an educator and a true educator's educator, I guess you could say, to our department. And the way that you work with all of our teams to make us a better version of ourselves is something that I'm hoping we can pick your brain about, Warwick. How are you today?
Yeah, how's it going, Eve? Thanks a lot for inviting me and for the kind words. So yeah, no, looking forward to it. I think it's going to be a really good discussion.
Wonderful. And next we have Parissa Cresswell joining us. She is one of our emergency department nurses as well, who is starting to dabble in some research specifically related to what makes people happy and satisfied in their job and able to do their job as best as possible. She is the proud owner of a couple of dogs, and I see a new kitten as well, so that's exciting. But I've invited Parissa on our panel because there is nobody in our emergency department that has more enthusiasm and energy and ability to draw people into a shift regardless of what is happening on the floor. And I'm hoping we can figure out how we might be able to channel some of that today, Parissa. Does that sound good?
Yeah, g'day, mate. Bloody stoked to be here. I think this discussion is going to be ace, and yeah, I'm really keen for it.
Wonderful. We may get work to translate a few phrases for us along the way, but I think what I heard from there, Parissa, was a lot of excitement about joining some Canadian colleagues. So we will invite our final panelist here, who's Victoria Brazil. Some of you may know she is a professor of emergency medicine and the director of the simulation service here. I've asked her to join our panel today because she is responsible for a high performance teamwork strategy at the Gold Coast University Hospital. And in that works with teams all around the place to understand how they can do their work better together. So has some insights about team science and may provide a few frameworks to make sense of what our panel gets talking about. How are you today, Victoria?
I'm very well, thank you, Eve, and thanks so much for inviting me. And it is pretty special to be able to be here with some of our colleagues because too often we're trying to talk about them and not with them. So this is great. One of the other things I just point out, even as you did your introductions, is how making things explicit and overt is a really helpful thing because many people do this great work and we don't yet know the names to put to them. And that's one of the things we certainly try and do in team development and team coaching.
Well, we will be turning to you throughout the morning to give us some actual names for those things that we maybe know, but don't know exactly how to talk about. So I thought to get us started here, I wanted our panel to think about what are some of the challenges that we have when we show up to a shift. So people in the audience in our panel, I want you to picture the last shift that you showed up to. Perhaps the department was overcrowded. Perhaps there was a high degree of acuity. Maybe there was lots of handovers, a challenging shift that you showed up to. And at work, I'm wondering if you might be able to share one or two of the things that you find most challenging in some of the shifts that you've had lately.
Oh, thanks, Eve. Yeah, the shifts lately have been tough. And that's just because there's just so much uncertainty because with the new COVID wave that we're experiencing here in Australia, there's just the run sheet for the day tends to change every day, or if not twice during the day as well. So no one knows exactly what we're actually dealing with. So a lot of the questions that we have from our nursing staff and our sort of junior doctors are to do with like, what are the testing protocols, which patient goes where? And there isn't actually a correct answer to those questions. So one of the themes that we've been trying to use is just basically use common sense and advocate for the patient. And that generally goes a long way to getting you through. The other thing that has, oh, sorry. Yeah.
No, go ahead. That's fine.
The other thing is just the fatigue from the staff, in particular our nursing staff, because our nursing staff have been really short. They've all been doing huge double shifts. And that fatigue after doing that for a couple of months is really setting in. So from the medical perspective, we really can step in and help our nursing colleagues with some of the tasks that they do as well, and certainly should be mindful of exactly what they've been, like how they've been carrying us those last couple of months.
Yeah, and before we dive into all of that, I guess just for some context for our viewers back in Canada, we recognize that we're in a bit of a privileged position in that we have had a different experience with COVID than has been the case in Canada over the past 2 years, really. And so we're actually at an earlier stage in some of the learning around the clinical side of COVID. Our emergency department departments have been struggling with all sorts of other issues related to access block during that time that are relevant, but we're certainly mindful that our acute experience with COVID is a little bit shorter than yours. And even with that, the fatigue and uncertainty that work is talking about is very real in our departments. Summers, from your perspective, work said a few things about nurses here. What are the challenges when you show up on a shift?
Yeah, I appreciate what Warwick said, and I all think it's very relevant. It does tie into what I've kind of identified quite well too. Some of I guess I have a bit of a double prong fork here. Kind of my issue is a lot of, because we're moving those goalposts possibly daily, and sometimes, as he said, twice in the day, how are we prioritizing our care, and how are we managing the expectations of those other people that at one stage at the start of the day were our priority. But now they seem to have shifted to the back, and we've paid attention to a different cohort of presentations. And maybe those people that once were told, you know, we're going to see you in this special area, I apologize for moving you here, they get left there and not moved to the new area because we've changed our goals. So I think that's one of the things that I've identified recently that comes up. And I guess that leads me to a second area, which is how do we prioritize these people and give them the expectation? Do we get a senior medical officer to come out and say, hey, look, I know you want to talk to a doctor because they're the ones that might be the best to sort this out? Or do we say, look, are you happy if you can have this discussion with me? I'm open-ended and I can talk about whatever we need to. What can I do to get you across the line to help you out today? They're two of the things that I've really noticed lately.
Yeah. So when I listen to both you, Summers, and Warwick, what I hear is a lot about some challenges with navigation, and maybe feeling like we're not capably navigating through our emergency department care in the same way that we usually would. And that makes us feel like we're maybe not doing our job as well. And a little bit about perhaps a little bit of uncertainty is okay, but maybe too much is problematic. Vic, I don't know if you have any thoughts about these issues or these bugbears from Summers and Warwick from a team's perspective. Why is this challenging for our teams?
Well, the first thing is to empathize with them. And I think particularly what someone's had to say illustrates your point about how difficult it is when patients being at the center of our care is so central to us, and then we find we can't do for them what we feel they need. That's very inherently distressing. But to try and draw this back to a bit of a framework, there was a lovely scoping review about the sources of teams' stress in the Scandinavian Resuscitation and Emergency Medicine Journal last year. And they basically identified 3 things that cause teams to be stressed. One is what they call performance pressure, which is what am I doing a good job? How do I know I'm doing a good job? And so the shifting goalposts that people talked about is difficult. We normally know if we're doing a good job on any given day, whereas suddenly we're not so sure. Am I going to be the person that manages to break the infection control? Am I going to be the person that admits the wrong person or discharges the wrong person? The second source of stress was role pressure. And this is, again, exactly what Summers and Warwick were talking about. Hang on, I'm the tent doctor. What does that even mean? What does a tent doctor do? So suddenly my role is uncertain as well, and this causes stress. And the final one is time pressure. And I'd argue for us that is always there, and that's a central part of emergency medicine. Everyone's familiar with those challenges. So in some way, that's possibly the least at play here. But I think what's really interesting in this scoping review, they say, well, what happens to teams when they start to experience this stress? And what is they narrow their focus down at the very moment they should be taking a step back and being strategic. They tend to narrow their focus down and just rewrite that run sheet again to fix one problem, even though it might create a new one. And the second thing they do is have very unclear responsibilities, because Summer's not so sure if he should get Warwick to come out to the tent or if he should sort it out himself, or maybe get the acute Dr. Eve to come and sort it out. And then the shared mental models break down. And so the things that we can normally rely on to understand these things, we can't rely on anymore. So I think I really I love the article. It was, and I can put that in the chat for people if you want to put it then out there for people to look at. But I think that really helps understand this great feeling of unease and this mounting stress that we have.
Yeah, I think that's very helpful. And hopefully what understanding our team stress will do is actually allow us to move forward and think about some strategies that we can use to more positively approach these types of issues. And I guess that's where I want this conversation to go a little bit. So Sam, I think you've been working in the department for a while and have felt some of these stresses at the team level. What are the things that you do when you show up to a shift to try to help your team through that?
I think a big one for me is making sure I know everyone's names. It seems a bit ridiculous that a year into working in Gold Coast Uni Hospital, I still don't know everybody's names, but I really struggle. And particularly now we're all in PPE 100% of the time, and all we're sort of relying on is sort of essentially the eyes and maybe a bit of the nose. I find that really challenging. And so at the beginning of the shift, I just try and make sure I know everyone's names. And if we can, certainly, I'm looking in our PED section at the moment, certainly we try at the beginning of each shift to do a quick huddle where we get the team together and run through what we would do if a resus came in. And that serves as a bit of a reminder to make sure that we're going to fully gown up for every patient if it's going to be a resus, even if we don't know whether or not they're COVID positive. I think for me, that's been a really important thing, because I find it really hard, and I think it makes it feel like a dehumanizing aspect if you're sort of just pointing at people and going, I need you to do X, rather than being able to say, hey, Eve, can you grab this? Or Paressa, can you do this? I think that's a lot nicer.
Yeah, I really want to zoom in on this idea of names and focus on that for a second, because I think it's easy to write it off as a COVID problem. I assure you it is not in healthcare. Certainly before PPE, we have not done a great job of actually knowing people's names and knowing who's on our team. And I think you highlight really some of the importance behind that. Vic, we've done a little bit of research on familiarity and why that's important. Do you want to tell us a bit more about why names and maybe the little huddles that Sam talked about as critical for our teams?
Yes, well, of course, I'm really reflecting all the things that you have discovered in leading the research on this, Eve. But you're quite right. When it comes to thinking about team familiarity, that becomes, and you showed that when we were looking at what are the sources or barriers to psychological safety and hence performance in our emergency department, team familiarity came out as the number one. But that said, it isn't just our work in emergency medicine. I've certainly found in the teamwork development I've done with the labour and delivery teams and with the operating theatre teams and in ICU, these actually quite small interventions can make a really big difference. And I've really been astounded by creating these anything from 1 to 5 minute teams getting together and talking together, and what that can do to set the tone, to regain those shared mental models, and to reduce all that uncertainty that I think we heard about as the challenges. But it is actually a tribute to you, Eve, and people should look out for more publications coming from Eve about psychological safety, but in particular, the central role of this concept of team familiarity.
Yeah, now I think there's a number of us on this call who understand the importance of it, but actually taking that from an understanding and into action can be a little bit harder. So Sam says that she likes to get to know everybody's names. I know Warwick likes to do that too, but I know he doesn't actually do it all the time. Warwick, what gets in the way of you doing the things you want to for your teams? When it comes
the
to
start of shift huddle is just so valuable. And I know that, but I still don't do it all the time. And I think that one of the reasons is that when you're taking your handover at the start of the shift, you may be dealing with 15 patients who have plans that you may not necessarily agree with. And your own personal stress level then gets in the way of your ability to actually project out to do the right thing by the team. And I've thought about it, and you're doing your team such a disservice. And that 5 minutes that it takes to actually embrace like all of your team members into the plan for the day ahead, it's just such a worthy 5 minutes, but you sort of internalize your own problems and then they trump that of the team. And and it's a definite failing on my part, and something that that I do and I regret.
Well, I'm going to challenge you a bit on that, because Warwick, you're human. In the theme of the CAEP Wellness Week, you may seem like a hero most of the time, but you are but a humble emergency consultant. Paressa, what gets in the way of you telling Warwick to do a huddle?
Thanks, Eve. Well, crikey, there's so many reasons why we don't do our huddle. Sometimes you go on the floor, and as a floor nurse, it looks like a dog's breakfast. You don't know where to start. It's overwhelming. And then because like what Warwick brought up, we're usually fatigued. We've done extra hours. We're doing a double. And as a floor nurse, I can't go down to the billabong and create more staff out of mud. I just have to, work through it. So with that on board, you feel like a bit of a squash toad. So with that, I think you just get so overwhelmed in the now that you don't stop and take a breath and go, hey, I can put aside 30 seconds to introduce myself to everyone and spend that time. But I think because we're so fatigued and just overwhelmed, that really gets in the way, or for me anyway.
Yeah. So what I'm hearing here is lots of good intentions, but then coming back to Vic's original framework, this idea that we narrow and we focus instead of coming back out to a strategic level, and that being a fairly natural and normal things for teams to do when we're stressed. Vic, do you have any comments on that?
Yeah, I think this is really interesting. And just to introduce another even simpler framework, there is a difference between the task work that we do and the teamwork that we do. And this becomes a particular challenge for leaders, because what Warwick just described was, I'm torn between trying to do the teamwork leadership that I know needs to be done versus the task work leadership and just getting in and doing it that I feel is my immediate priority. And this is not unique to healthcare teams, but I think healthcare teams haven't done a very good job of outsourcing the team leadership. And if you look at things like sporting teams, that's why they have coaches, because those coaches do a lot of work in helping the team work, which allows the leader to still obviously contribute to that leadership, but also to think about the task work. And I think by vesting both of those priorities in one person, we have set ourselves up a little bit for actually quite unrealistic demands in some situations, and the kind of trade-offs that Warwick's talking about. And I wonder if there are, I don't know, but I wonder if there aren't other models where we could think about people taking a bigger role in helping to develop and coach a team and taking responsibility for that.
Yeah. Now, Summers, I've worked with you on the floor where I feel like you have done a bit of coaching for me on what I should be doing. What do you see as your role, and what helps you feel like you can do that on any given day on the floor? You can help us be a better version of ourselves.
I am flexible. I will fill the void where it needs to be filled, I think, a lot of the time. And that comes with, I think, a little bit of confidence that I've built up over the few years that I have been there. Sometimes when the department is chock-a-block and you need a chocky-bicky to sort out your day, it is easy to encourage people to come in, as Paressa said, a lot of the nursing stuff, if we can bring everyone in together, have the same goal, whether it be 30 seconds or 5 minutes. There is not a person working in an emergency department anywhere in the world that will not appreciate a laugh at one stage or another, whether it be an offhanded comment, or we can start the thing, introduce yourself. You know, sometimes I tend to, for the lack of a better word, take the pee out of myself sometimes, and it breaks the ice with this group. So you've got 15 people in a pod that go, why are we doing this? I've got things to do over here and got things, and you say, look, g'day, my name's Michael. I forgot to eat brekkie this morning and I'm absolutely spewing about it. But hey, if I get some chocky bickies and I can help you guys get together today, let's do it. All right. And then maybe I can get down the road and get something to help out the team. I think bringing everyone together is my kind of flexibility role, whether it be in the middle of a really sick patient. We'll try and dedicate some time just to get everyone on the same page. And I think together we would do such a better job. As Warwick said, if we can really set aside the 5 minutes, we can save ourselves 5 hours of stress.
So just before we dive into some kind of institutional and organizational supports that might allow us or help us do these good things, I just wanted to translate chocolate bickies for the Canadian crowd. That is some chocolate cookies. They're hard to find in our department right now, but if you can get your hands on them, very well enjoyed.
There are definitely none in kids.
None in kids. Fair enough.
Can I just make a little point here? And that is one of the things that team coaches need to do as they try and explore where teams are at and align their work and their behaviors with their values, is to identify positive deviance, like you have kind of identified in this group here today, Eve.
Mm-hmm.
So one of the unfortunate things about some of our approaches to trying to improve is we try and find the people who are no good and fix them. Now, maybe that's a useful strategy, but one of the other approaches that we can take is to find the people who are extremely good and who are contributing to leadership and teamwork in ways that is exceptional, and try and think about what it is that we do and help the rest of the team to get on board with that. So as I look around and, you identify people like Paressa and Summers and Warwick and Sam, and you think, well, okay, I have seen what they do. How can I deconstruct that a little bit in ways that clearly they don't even quite understand, and encourage others to do that, because there's so many lessons in what we do right.
Mm-hmm. And where do you think, Vic, how we should be doing that? How can we operationalize that in our departments and in our organizations? Because we're going to see this talk, but none of our colleagues in the department are going to see these excellent people talking about why they make such a positive impact on the floor. So how should we be doing that?
Yeah, I think there's two ways. One is to have the language, and the second is to have the conversations. So we've talked about a few frameworks for thinking about teamwork today, and I think it's good for all of us to have a lexicon that allows us to actually name things and talk about things. And secondly, to get an opportunities. And we've talked about the pre-shift huddle, but I would say the end of shift huddle is also an opportunity where we can say, and some appreciation to our team, but don't just leave it at that. Actually go a next step and say, yeah, it was great working with you, Summers, but this is why, and this is what you did. And others, I'd be interested to know how that affected you and what else could have been useful from me if I've been the medical consultant on for those shifts. So I think having the language and then having the conversation, and then Summers, we can pick up stumps and go home.
An excellent cricket reference there for the crowd. So Warwick, I know, and I have seen you actually have a variety of other conversations. So we've talked a little bit about pre-shift huddles, but there's some other things that can really get our teams operating at the best version of this kind of buffer between our systems and our patients as we can. And I've seen you do a couple of after action reviews with some of our sick patients. Can you tell us a little bit about that?
Yeah, so for the after action reviews, that has been largely from stuff that I've learned through watching simulations and debriefing them with Vic, and understanding that, like, when people are involved in a resuscitation, they have such a narrow view often of what's gone on that their own sort of small piecework involved in the overall complexity of the case means that they can often not appreciate everything that has happened. So that understanding that an after action review primarily is a sense making period for everybody has really helped me reframe the way that I approach it. And now with the after action reviews, what I want to do is firstly give everyone an opportunity to just summarize and get on the same page, and then allow individuals with their own individual perspective of it to then sort of like have a voice, be able to raise any kind of concerns, and then debrief from their own perspective. And to give an example of that, I was involved in a resuscitation with Vic for a young patient who actually passed away. And 2 weeks after that, one of the wardsmen came up to me and said, "Oh, look, I'm really, really sorry about what happened with the ultrasound machine. The one that was normally in that room ran out of batteries, and that's why it took me longer than expected to get the other ultrasound." And his personal interpretation of that resuscitation was that this patient may have died because someone had forgot to plug the ultrasound machine in and it took him too long to get it to the bedside. And that had no bearing in the case whatsoever. But he spent 2 weeks like thinking that over and wanted to try and seek us out to apologize for his perceived deficit. And that a good after action review would have given him a voice to actually raise that then and just reduce that morbidity over the next couple of weeks.
Wow. Yeah. Thanks for sharing that story, Warwick. I think that gets to the heart of one, thinking about our teams fairly broadly. I know here we have emergency physicians and nurses, but there are more people that make up our team than that. And two, this link between our conversations, the sense that people belong, and then also their performance. Because I think the other thing that conversation could raise is, well, why do we have a problem with our ultrasounds? And is there actually something that we need to fix related to that? And maybe, just maybe, this wardsman has a great idea that will make our environment more functional and more useful. And so the worry that I have sometimes with these conversations is that it's talking about very kind of light stuff, but it gets at performance and us doing our job as good as we can. Vic, I don't know if you have any comments about navigating conversations that some maybe perceive as light and fluffy, but really are at the heart of doing our job well.
Well, I think what they, just as you indicate there, they can be the connection then also to those both individual and system level interventions that we know help us do our work well. So I think it's not just also about reinforcing the team and addressing individuals' needs in the team, but it actually then spills back out to those other layers that you have indicated help us capably navigate uncertainty together. So, but I think they're hard to have as well. And interestingly, in that case, we we did have a after action review or hot debrief, but it's very hard when you've got 15 or 20 people who are involved in a case. And I think just normalizing, though, the fact that we will have reflective conversations about what goes on and try and help people make sense of them is a good thing. And I think, unfortunately, a lot of this so-called debriefing literature has been very situated in maybe cases like that are more critical and distressing, whereas I think we're going to have better conversations in those situations if we talk about other things like, how did we go getting to CT safe and fast with someone just the other day, even if it wasn't something critical? How did we go doing that RSI in a toxicology patient that wasn't particularly difficult, but which we could just run through the process? So I think normalizing performance conversations is also a really powerful thing for a team.
Yeah. And to do that around cases that aren't so wrapped up in people's identity or other emotions makes having those conversations around getting better a little bit easier. Now, I am aware that we jumped into this conversation all from what Sam does at the beginning of her shifts to get her team aligned. But I know Parissa has a few things that she does to help teams capably navigate uncertainty together when it feels like the odds are stacked against us. So what types of things do you do to help your teams, Parissa?
Well, Eve, you know me too well. And what I absolutely love is just appreciating the heck out of the staff I work with. Because like I said before, I can't create stuff. So I may as well adore the ones that I'm working with and just remind them how much I do adore them and that I do. So I guess, what does that look like?
Yeah.
So 2 things for me that I try and endeavor each shift is doing these frequent individual check-ins. So whether it's a doctor, a nurse, a wardie, a radiologist, checking up on them and saying, 1, have you had your break? Because I think with fatigue, it's so toxic and because there's so much to do, you think, oh no, like a break isn't important. That's okay. Like, I'll have a chalky biscuit and a cuppa when I get home, or more like a beer. But you need to make your colleagues have a break. And even if it's just helping with the patient load, or even just finding a bladder scanner for your colleague, because sometimes they go rogue in the department, or even just doing like a rat test, so then it helps that patient flow for your colleague. It actually, those little things add up. And I don't think people realize how much it means to people. And I think my fair dinkum favorite thing to do, and you know what's coming, I think all you guys know what's coming, is personalized positive feedback. I absolutely love pulling people aside and telling them not just that they're ace, but why they're ace, why this shift that was so important to me, and how I probably couldn't have done it without them, and how much I appreciate them as a work colleague and as a friend. And I think, I know a lot of people think, oh yeah, that person's really nice, but why don't you tell them? Have the confidence to go up to someone and tell them why you think they're great, because 100% they'll love it. And I have had no restraining orders so far. So I feel like that's a positive.
Well, I mean, just speaking from some personal experience, Parissa, I remember about a year ago when I moved down here and was a new consultant in a new system and felt entirely overwhelmed and like I didn't belong. And we had one of these conversations where you gave me feedback about a very small thing, and it made me believe that I could come back and do it all again tomorrow. So these small conversations, these small moments, they do matter to people, but it also makes me more likely to pass that along to somebody else on my team. I just, with our 10 minutes left, we could talk all day, but just want to encourage anybody in the audience to ask any questions or to challenge some of our ideas, to push us on the practicalities of how we do some of these things, or any other reflections or tips that are used by others to make their teams the best buffer possible. While we're waiting for some of those questions to come in, Summers, I thought I might ask you one more question, and specifically as it relates to, I know you've been doing a lot of work kind of at the staffing level and rostering, and do you think there's any organizational level interventions, things about the way we roster, the way we set up our teams, that might seem a bit heretical. They might seem a bit crazy, but would maybe help our teams do a better job.
We've had some interesting changes in the last few years. I think some of you might be familiar with our original, when we moved to this hospital, we went away from team nursing. So we changed our roles into being individualized and accountable nurses. And that was what they stated that as. So they wanted more accountability for our patients. So we went to a 1-to-3 ratio in our more acute areas, whereas that used to be 2 nurses to the 6 patients potentially. Now, we've only recently gone back to team nursing, and it's been what I would say, a change for the better, my personal opinion. Don't quote me. But we've seen this change back due to, I think, a lack of teamwork or possibly people a bit disconnected with one another, and roles and responsibilities are becoming quite difficult for maybe one person with 3 acute patients, and someone else may have some empty spaces. And to bring it back to team nursing, we share conversations, we get to know who we work with better. These huddles and things become quite easier, that Sam's earlier mentioned. The goalposts that Warwick mentioned earlier are coming more into line because we're talking about the same goals with our patients across, and we're sharing our experiences. And hey, those breaks that Paressa has just mentioned, they become a bit clearer and easier to see too. So we are moving, changing our model in the department to reflect our needs. And at the moment, our needs are teams. And what better place to, discuss that is than a forum like this.
Yeah, Vic, do you want to comment on some team-based rostering and why that might be important?
Well, I guess it does go back to just, it's much easier to create that team familiarity and all that uncertainty that we were talking about right at the beginning. You can remove some of that if you're used to working with people for a block of time, for a block of shifts, whatever it is. That is probably going to be structurally so much easier than to get that shared mental model on any given shift, because you've got some things that you can rely on that will be shared, almost micro values within that team. I am just cognizant, also have a couple of questions that have come up. Mm-hmm. Thank you very much to everyone. Hello, Carrie Samsel. There's actually some themes in there about what's the practicality of doing this. How do we fit it in when we're so busy, or actually when you just don't feel like it and you haven't got the energy to be able to get. And I agree, it's an insightful question, because actually sometimes you do feel like that. And I think the first thing to say is, I don't have a perfect answer to this. We all know cognitively the answer, which is you take 5 seconds and it saves you 5 minutes, and you take 5 minutes and it saves you 5 hours. We all know when we haven't done these things, the stuff that sometimes we have to unpick because of the failure to have a little plan. Now, that is easy to say. I'm totally aware of the fact that it's sometimes hard to enact. But I think what it brings up is, and I suppose one of the things that I might bring to this conversation is, we think we know each other and our work in emergency medicine. And I've had some quite interesting insights when I've gone to other teams and I haven't been able to assume what I think about a team. And I found I've been much better at exploring people's work, the things that gets in the way of doing some of this teamwork, the things that gets in the way of people doing their task work, because I'm not as familiar with what they do on labor and delivery. I'm just not as familiar as what they do in the ICU. And so I think if for people who are looking to lead and coach their clinical teams, probably we need to spend a bit more time asking questions and diagnosing before we then jump into a solution. And I think it's very tempting to say, oh, here's the recipe for great teamwork on a shift. Whereas I think what we should be doing is spending a bit of time as a coach really trying to understand what are the disconnects between those values and our practice, what are the things that people need to do their job well, and what are the things that do get in the way of that teamwork on a shift before we then start prescribing interventions. I think the principles of what we've talked about today are fantastic, but I also think there's a couple of other challenges in there that lend themselves to listening as well as talking.
Yeah, and I would just add, specifically the work that I've done as an anthropologist is so contextual, and everybody's emergency department is different, and the practicalities of sorting out what your department needs is something that takes time and trust, and maybe just an applied anthropologist. So I'm kidding. This is something that you can all do. But I am aware that we're just running out of time here. And I wanted to give our panelists a final say in any top take-home tips when you show up for your next shift and you are hoping to help capably navigate acuity and uncertainty together. What would you suggest, recognizing that a prescription is not perfect, but ideas are where we start? Warwick, do you want to give us your top tip?
I suppose for me, like I'm just labeling the dynamic, saying that this is stressful and uncertain times. People are tired, and just to be gentle on yourself and each other. And for me, that definitely helps, because I'm not performing at the level I'd love to perform at in an ideal world. But normally I'm doing a pretty good job, and I should just be grateful for that.
It comes back to naming the dynamic. The people at Queen's are glad that I haven't changed my riff there. Yeah. Summers, what do you suggest as a top tip for showing up and helping your teams be the best version of themselves?
I am learning from every single person in my team, and whether that be cleaners, wardies, nurses, doctors, allied health members, pharmacists. I am just taking it all in at the moment. When it gets tough, I take more in. And if it gets tougher, I try and take more in. So I'm just trying to learn from every single person and build a better me. And if they learn from me, I think it works both ways.
Well, we may be coming for some of that departmental wisdom shortly as we try to navigate this all. Sam, top tip for our Canadian listeners.
Yeah, I think, I'm about to head to work, and I think I'm just going to jump in and say to the guys, okay, who needs a break, and what can I do that will make what you're doing right now easier? Because I'm coming in fresh, and you guys have been here for, 5-6 hours. So, let the fresh team come in and take some of those jobs off you.
And some practical things to facilitate that. I like it. Parissa?
Well, I guess you have to remember, it may look like a dog's breakfast. You feel like a squashed toad, but remember, you're not alone and you will get through this. And the best thing about an emergency department is kind of like what Summer says, we're a team and we're a family, and you do change people's lives. And that's the best feeling to have. So just don't give up.
Yeah, I think that's is certainly a wholesome message. And I feel that on the floor when I'm working from you, that we can get through this. So a bit of a beacon in challenging times. Vic, what would your take home be for our listeners?
I would agree with all those suggestions so far because they are excellent. And I would add trying to also create this teamwork conversation at a strategic level. And I think designating some people or person in the department to be trying to continually push the agendas of have we got some language and some opportunities to talk about our teamwork and helping people advance their own personal skills in that as well.
Well, thank you very much. I certainly look forward to showing up for my next shift so that we can all capably navigate acuity and uncertainty together, or at least give it a crack. I think I'm going to pass it over to Louise to end things out for us here. Thanks for joining us.
Thank you all so much for such a fascinating conversation tonight on appreciating and cultivating our teams. And I think discussions like this, I think, get us a little closer to recognizing ourselves again, Eve. So thank you for leading such a great discussion. And Parissa, I think across the Canadian Emerge departments, tomorrow you may find that people are being called ACE and told exactly why they're ACE, which is not part of our normal lingo. So thank you to all of you. So to Eve, Warwick, Summers, Samantha, Parissa, and Vic, thank you for sharing your knowledge. And if you do see a rise in Canadian applications to your department, I think you'll know what the index event is. And to everybody who tuned in tonight, thank you very much for sharing a little bit of your precious time with us. Thank you.